Aman?
Yes, sir. You can start. You can start.
Okay. Good evening and welcome to this international webinar at Believers Church Medical College Hospital. We apologize for the delay in start. We had a few technical glitches which we had to iron out. So thank you so much for waiting. This is our 41st webinar, and today we will learn about an overview of chronic kidney disease from a distinguished international faculty. Dr. Paul Murray-Bezos is a consultant nephrologist at the Tifts Regional Medical Center in Tifton and at the 360 Kidney Care LLC at Brownsville, Texas in the United States of America. Awarded the Resident Teacher of the Year Award from the University of Texas, Dr. Bezos graduated in medicine from Mexico and went on to become American board rigorously from the University of Texas Health Sciences Center, Houston, Texas, US. As a visiting lecturer at Texas, and also provides general medical care to the people of Haiti through the organization Caribbean Helping Hands. Astute clinician, brilliant academician, and a man with a compassionate heart. It's a great privilege to have the Bezos with us. Sir, welcome to this international webinar. It's a great honor and privilege to host you. Our moderators for the session include our extremely efficient, dynamic, and charming nephrologists, Dr. Gio Philip John and Dr. E.T. Arun Thomas, trained in Canada and UK respectively after their super specialization in nephrology from prestigious institutions in India. Welcome Dr. Gio and Dr. E.T. Arun Thomas to this international webinar. To give an overview of the session and to hand over the proceedings to Dr. Bezos, may I request Dr. Gio to take over. Over to you, Dr. Gio.
Thank you, Dr. Jacob, for the kind introduction. Good evening, everyone. Greetings from Believers Institute of Renal Disease to all the participants. Today, we are having an important topic, chronic kidney disease. As you may know, in India, diabetes mellitus and hypertension account for almost 40 to 60% of patients of chronic kidney disease. And since the number of diabetes patients are on the rise and India being labeled as the diabetes capital of the world, the number of chronic kidney disease patients are also going up. So it's one of the data shows that over 50% of the patients with advanced CKD present to a nephrologist when the eGFR is less than 15 ml per minute. So considering the huge financial burden on these patients in regards to the dialysis and renal transplantation, it's very important to identify the kidney disease in its early stages. So to enlighten us regarding this topic, I welcome Dr. Paul Murray-Bezos to this academic session. Over to you, Dr. Paul.
All right, thank you very much. I really like thank you for the invitation. Jacob, about maybe 3 months ago, reached out to me via LinkedIn, and we've been connected there, and he said, hey, we would like to give a talk to the medical student and the medical. I'm saying, sure. Now, the problem has been like trying to get the schedule. As you know, right now I'm on the East Coast. It is 7, it's gonna be 8 o'clock here in the East Coast, but I live really in mountain time in Montana. So over there it will be 5 in the morning. So anyway, I'll be working for the next 3 months as Jacobi Hospital here in the Bronx with the hospital system. So thank you for having me, and let's go right to it. Perfect. So you're gonna share your screen, right, Dr. Jacob? Perfect. All right. Let's go to the first slide. Let's make it big. All right. So what we're gonna try to do today, this is the word map. The first thing, we're gonna try to define what is acute kidney injury. As we're trying to say, the goal today is overview of chronic kidney disease. But for us to get to that, we have to define what is acute kidney injury and a brief management of acute kidney injury. This is more for hospital setting. in the outpatient setting, as I was saying, it's kind of different. You know, if I see someone with acute kidney injury in the outpatients, I don't have to get lab the next day. I don't have to get follow-up the next day. Sometimes I can wait a week or two, maybe 10 days to have them coming back. And then after that, we're gonna define what is CKD, and then we're gonna say what it would be a minimum initial workup for CKD. And then after that, we will talk a little bit about the long-term management of CKD, mainly in the outpatient setting. Next slide, please. So to define AKI, maybe about 20 years ago, there was no definition of acute kidney injury that everybody was using. Every physicians and every part of the world was using different. But about 10 years ago, they have the RIFLE criteria, the Aiken, and then as nephrologists, we adopted Cadigo criteria. So, so there's probably either for Cadigo stage 1, we say that there's an increase in serum creatinine more than 0.3 milligram per deciliter. Maybe in India, you guys use different, but you'll be able to change it anyway. That's within 48 hours. Increase more than 1.5 times the baseline, which is none or presumed to have occurred in the past previous 7 days. Or the other one will be decrease in urine volume no more than 0.5 ml per kilogram for more than 6 hours. So as you can see, depends on the setting, right? So if someone is in the ICU or the ICU intensivist, they'll be using the 0.5 for more than 6 hours. If me in the outpatient setting, I'm seeing someone, I'm gonna say, what is the baseline creatinine? What the one that I presume to know or what I think I know? And then if that happened the previous 7 days, right? But the one that all of us, sometimes we keep in mind, let's say if someone have a creatinine of 1 and then you see them with a serum creatinine now of 1.3, you're like, oh, that's 0.3 increase, that's AKI. Now, depends on the increase, we're gonna go to stage 1, stage 2, and stage 3. Next slide, please. Okay, so as you can see, now, a lot of times people would say, oh, this is really good for when you do studies, but I still put them in my note. When I see someone, I still put them in my note because that also helped me going back, right? So if I see someone the first time as a consultant nephrologist in the hospital setting, I'm like, okay, this patient have Cadigo stage 1, and then this is my definition of Cadigo stage 1. And then if I go either by the serum creatinine or the urine output. So if it's like 0.5, less than 0.5 ml per kg for more than 6 to 12 hours, that's stage 1. More than 12 hours, that's stage 2. And more than 24 hours, that's stage 2. Now, if there's no urine for more than 12 hours, that's stage 2. Now, also, you're gonna see when using the serum creatinine, if I start as a nephrologist, if I start kidney replacement therapy at any given time, it doesn't matter what was the reason, this is Cadigo stage 3. Now, if the serum creatinine is between 2 to 2.9 times of baseline, this is stage 2. Now, this is AKI, acute kidney injury, Cadigo stages. I'm sorry about the I there, there's no I in the middle. Any questions here?
No, Doctor. We can go. We can go ahead. Yeah.
Okay. All right. Next slide, please. So that's important. I think this is, if I'm gonna, there's like 5 slides. I will say those are very, very important from this talk, and I think this is one of them. And I think if there's medical student here, this is directly from the Cadigo guideline. The reason I put it there, because remember, this talk I give to medical students. They like information in the slide. If I don't put much information, they'll be like, oh, good, but it doesn't help me to study. So that's why I put it there. So the first thing you need to know, or you try to do, try to see what was the reason the patients have the acute kidney injury whenever possible. Just don't say acute kidney injury, we're gonna do this and that. No, try to say something. Try to come with an idea. There was hypotension. The patient started with a new medication. There was a non-nephrotoxic. Patient was taking antibiotic. Patient was taking NSAID. Patient was taking PPI. Proton pump inhibitors, pantoprazole, all those things. Or some reason, try to come up with something. And also, when you're trying to do that, you're going to recommend the patients, you stratify the patient risk, depends on the chances to have exposures to things. Manage accordingly to those risks, and then monitor the patient's AKI. Same thing, all those are Cadigo, you guys can read the slide. Manage the AKI according to the stages. All right. Next slide. All right. This is another one that's important. Now, the main reason I put that is because this is again Cadigo Guideline. Here in the US, we usually try not to put, when we're gonna start someone on dialysis, we try to put only IJ, right? Either we do turnout or non-turnout IJ. But for some reason, there's some intensivists that still put subclavian. And then we don't want that. And as a nephrologist, we don't like subclavian because we know subclavian catheter has increased risk of stenosis, right? So this is the step-by-step guideline from the Cadigo. Again, the first thing we said, before patients, when someone, just keep in mind, globally, about 40% of patients that get into ICU already have some degree of acute kidney injury. And up to 58% of those patients that are gonna get into ICU gonna develop some stage of acute kidney injury. So those things are important. So what do? You try to prevent, right? Someone which is high risk, what you do, discontinue all nephrotoxic agent. Oh, one more thing. I told the fellow and the resident, don't write nephrotoxic agent. No, that's very global. If you review the patient medication and say, hey, don't use vancomycin with piptazole, piperacillin, and tazobactam because they have increased risk. If you're gonna use vancomycin, use it by itself. If you're gonna use it with maybe meropenem if you have it. But try not. If don't use NSAID, don't say nephrotoxic because any medication can be nephrotoxic. Saying nephrotoxic doesn't really help the primary team, right? So avoid hyperglycemia. I cannot really stress that much. And then as nephrologists, we all know someone who have hyperglycemia, diabetes or not, if you put someone on steroid, they develop hyperglycemia, they have an increased risk to have acute kidney injury. Why? Because that glucosuria will cause osmotic diuresis. That's another way, and then that could cause dehydration. Patient might have volume swelling, but they still be intravascularly volume depleted, right? And also consider the functional hemodynamic monitoring. And then there's so many things we try to do here in the US, but studies after studies have shown probably the best thing you do. You see a patient, you can use the ultrasound we have bedside to look at IVC. You can put swan gains, which we don't do anymore, but moving the patient leg, right, up to his chest, and then while you monitor that, that's dynamic. That can tell you the volume status of the patient. Ensure volume status, as we said, and then for stage 1, we do non-invasive diagnostic workup whenever possible. Right now we're using a lot of what we call neph focus, ultrasound at bedside. Check for changes in drug dosage. That's very important because if someone have AKI, you have to adjust the medications. And that's when in stage 2, that's when we start talking about renal replacement therapy or kidney replacement therapy. Now, whenever possible, if we try to use continuous renal replacement therapy, especially in patients who have hypertension, or we use regular dialysis as well. And then we consider ICU admission. And then the main important thing for stage 3, we would say, do not use subclavian catheter. Next slide, please. So now, if for all of you medical students here, I would recommend go to AJKD core curriculum and then you look for ICU core curriculum. It is free. It is 18 pages, very nice. That will tell you a lot about AKI in the ICU and acute, management of the ICU. This slide is directly from the previous one. So what is this? So we try to come with things to predict people that's gonna have acute kidney injury. As you can see, when I was a fellow in UT Houston, NGAL, which is the last one, was part of the one that we were part of the studies, and then I think it get FDA approval, and then Kim 1 also get FDA approval here. So some of them are better to predict in mainly in ICU patients, and then but also there's one I don't have here, which is also good at predicting what will be someone who go for surgery who will have acute kidney injury. But now, one thing I don't have on my slide, what I should have, is furosemide stress test. Now, furosemide stress test is anything else than Lasix. Let's say someone will have acute kidney injury, oliguric or non-oliguric, depends if the patient is never been on Lasix, we call that Lasix naive or furosemide naive, or if they've been on furosemide, you give them, the dose is different. You can go all the way from 160 to the max of 200, and then you give it at a 0.0, and then you see how much urine that patient make the next 3 hours. Depending on that, it will not only give you what is the chance for that patient to progress to later stage of acute kidney injury, but it also will tell you if that patient is more likely to develop need renal replacement therapy or kidney replacement therapy. So, but because this is something cheap, you're not gonna see much about it. But when you look at all the studies, it is as good as, there's only one, I think it was the Kim 1 or LCM 1 that did better than the furosemide stress test. So next slide, please. Now, I kind of mentioned that because sometimes we get confused. What is acute kidney injury? What is acute kidney disease? What is chronic kidney disease? So we think acute kidney injury is something that you can have acute kidney injury depending on the stage 1, 2, or 3, but that can stay up to a month, right? But if after a month your kidney function is not back to baseline or close to baseline, we think you have acute kidney disease. And then that acute kidney disease can go for another 2 months, right? All the way before we can call you chronic kidney disease. So either you believe in acute kidney disease as a separate entity or not, but what we really think is for you to have chronic kidney disease, that increase in serum creatinine should be at least 3 months, or that kidney disease, acute kidney disease should last at least within 3 months before you tell someone have chronic kidney disease. That's very important, because when even here in the US, when we tell someone have chronic kidney disease, we're like, oh, so chronic kidney disease, we don't have to do much. But when it's acute kidney injury, we look more. We're like, oh, maybe we do that. Maybe we give you some fluid. Maybe we try this. Maybe we do that. Maybe we back off some of the medications. But in chronic kidney disease, sometimes we're like, okay, all right, see me in a month. But if you think someone have acute kidney injury, you want to see in a week or maybe in 2. All right, next slide, please. So the whole thing we talked for the previous 15 minutes or so, it has to do to get to this. What is chronic kidney disease? All right. Chronic kidney disease is kidney damage, as we know now, for more than 3 months. Now, very important, is defined as either structural or functional abnormalities of the kidney. Structural abnormalities, we're thinking about if you have polycystic kidney disease, it doesn't matter what is your GFR, you have chronic kidney disease. It can be stage 1, it can be stage 2, it can be stage 3, but you have chronic kidney disease. If you have multiple cysts in your kidney, you have chronic. If you have 3 ureter or 1 ureter or messed up ureter, you have chronic kidney disease. Now, so Now, if you have diabetes, we assume you have chronic kidney disease. If you have hypertension, we assume you have, but for the functional one, we're really looking into, do you have blood in your urine? Do you have protein in your urine? Do you have, any other functional abnormalities? So next slide, which is basically the same thing. Okay, so next. All right, so now, when we talk about chronic kidney disease as nephrologists, we like not just to say stage 1, stage 2, stage 3, stage 4, and stage 5. We like to put what is the degree of albumin in the urine. Either you use albumin creatinine ratio or you use protein creatinine ratio, but we like to measure the albumin. Why? Because studies after studies have shown if you have chronic kidney disease and more albumin in your urine, you are more likely to progress, right? So when we say that I'm seeing someone and I'm gonna say, okay, patient GFR, calculated GFR is 43, right? So I'm gonna put that patient in CKD G3B. And then I'm gonna look at the albumin, and then if the albumin is less than 30 milligram per gram or 3 milligram per millimole, which we don't use here in the US, I'm gonna say it's A1. Now, if it's above 300 milligram per gram, it is stage 3. Now, when to refer to nephrologists? Basically anything in red here, you can refer to nephrologists, right? So as you can see, someone will have a G3B, but A3 is in worse shape than someone who have G3B A1. So you can be G3A, right? But because you A3, you have more albumin, we think you're gonna progress more, right? So again, that's the mainstream of treatment. As you're gonna see, that's why we're trying so far. Every treatment we have done, we are trying to get to chronic kidney disease except one, which is bicarbonate. Everything else have shown really, if they're gonna improve or slow the progression of chronic kidney disease, they have to do something with the albumin. As a matter of fact, the FDA right now will not approve any drug that who doesn't do anything with albuminuria in the kidney for kidney purpose. Next slide. So this is all data. That's from all the way to 2006. As you can see, 11.5%. And I only believe that's gonna be worse after all those acute kidney injury or acute kidney disease. And then a lot of those patients now, with the 20 million of patients that we have here in the US with COVID, we only expect those numbers to go higher. Next slide. All right, now, I could stop the talk right here. If you can tell me, if you ask me, hey, Doc, let's talk about chronic kidney disease in one slide, this is the slide I'm gonna take. As a matter of fact, that slide is so important for me, what I do. This is the same slide I kind of use when I'm seeing patients in my clinic to do what we call paraphrase, just to see what I'm gonna go writing and documenting and then looking for. So chronic kidney disease, the first thing we look at, sodium and water balance, right? Now, we know if you end up having chronic kidney disease, you have at least here in the US, you have a good chance, you have like 50% chance to have diabetes. And if you have diabetes, you probably already have hypertension, because as we know, diabetes can cause hypertension, right? So now if you have chronic kidney disease, it might be because you have hypertension or diabetes, but if you have chronic kidney disease, you don't have hypertension, you are more likely to develop hypertension because you're gonna have problem with sodium and water balance. So that sodium water balance can cause hypertension directly, right? Or it can cause increased vascular volume, right? And then that sometimes can cause edema, right? Lower extremity edema, what sometimes we look for. And that can cause heart failure. And that heart failure, right, that's one thing. Now, as you can see, we're going to talk about treatment later on. We're going to see a lot of drugs are focusing on that. So hypertension itself can cause heart failure as well, right? Because it's too much fluid. So there's two ways those patients have issue with water and sodium and water balance. Now, the next thing is potassium balance, right? Now, we all know that we say, okay, potassium balance patient going to have hyperkalemia. Now, since we're talking about that, I want to say something, and then please, the two consulting nephrologists that's on the top, let me know what you guys think about that. Because one of the things I'm gonna be talking about later on about treatment is about nutrition in CKD. And then one other thing I'm gonna mention the DASH diet. And the DASH diet is a diet that is high in potassium. And then that's a diet that's been shown to decrease the progressions of chronic kidney disease. Now, since I'm saying that chronic kidney disease can cause potassium balance and can cause hyperkalemia, so when I'm going to tell patients with CKD stage 2, 3 to go in a high potassium diet, this is not controversial. It is not. It is basically the people that develop hyperkalemia, they're really in late stages, right? So it's not something but when you see some hyperkalemia, it's because they're late stages, and sometimes CKD4, CKD5, and sometimes because of medications we give them, and sometimes also diet. But before we talk about diet, we need to talk about medications. Now, the next thing is eliminations of nutrition is wasting. Now, that uremia that I've seen in Haiti, because that's where I'm originally from, I don't really see it much here because people don't really come here with with that grayish skin color, that uremia. The uremia we find here is more subtle, and sometimes it has to do with actual mental status or decrease in cognitive abilities, right? And then in Houston, I saw some pericarditis because those patients, they don't have access to, because some of them don't have, they're here in the country, they don't have legal status. So that's why sometimes we'll see pericarditis. And since I'm talking about that for the medical student, there's something they call nephrogenic pericarditis. If you see that, this is really bad. Those patients, they die within two years. But it's really patients that need to be on dialysis, that not receiving dialysis. But the pericarditis you see at first is a much different one. And then the other thing I like to talk about medical students when we're talking about the uremia is the neurological manifestation of that, right? So it's the neurological manifestations. And then I remember one of the patients that I started dialysis when I was in Houston. I mean, BON was like maybe 80, creatinine was 4, and then we try not to start those guys on dialysis because they don't have access. They don't have a way to get dialysis as an outpatient. They only have to come to the hospital. But the reason I had to do it is because he had hiccups. He had that hiccup. He was talking, and then for me, I didn't think much about it, and I'm like, okay. And I went to my attending. I said, look, not bad. I mean, it's there, but the only thing, he had that hiccup. He's like, oh, okay, that's probably due to the uremia. Okay, this is a neurological manifestation of that. And the other thing is sexual dysfunctions. By the way, that's for men and women. Decreased libido, right? That's one thing. Skin disorders, we all know about those, the pruritus, and then the impaired immune system. As we know, those patients, their platelet, they might be 200, 300, but they don't really work, right? And then the increased risk to have more other things than other people. And then also the coagulopathies, as we talk about the uremia, the bleeding, erythropoietin. Now there's some really good advance that, as you know, those HIF, PIF, those new medications are gonna try to stimulate erythropoietin instead of giving someone ESA. Now they're in the work that we're probably gonna have them, give them those type of medications that are gonna stimulate their patients on to do those erythropoietin instead of giving them erythropoietin. Some of them are in the work. The acid base, and then the main thing when we talk about acidosis, but what are the factors with acidosis? Acidosis causes so much problem. We're talking about bone problem, the whole thing we call CKD and BD, which we're gonna talk about that as well, and then also skeletal buffering, that can cause to problem with vitamin D, and then problem with phosphate. As you can see, this is a loop that can cause more hypocalcemia. And then the last thing we like also talking about is hyperparathyroidism, that we think is, we call it renal hyperparathyroidism. So those patients, as you know, they're gonna have hypocalcemia, hypophosphatemia, and sometimes the PTH is gonna be very high. And then what we try to do for those patients is usually, oh, they have vitamin D, let's correct that, all right? And then here in the US, we use a lot of vitamin D analog, calcitriol, but sometimes the problem with that also can cause more hyperphosphatemia. And also we use those, what we call Sensipar calcium mimetic. But the main thing we're gonna see is come down to one thing, nutrition. Next slide. Next slide, please. So just in a way to mimic the previous slide, this is the initial workup that I usually get. So this is where I'm gonna ask, hey doc, the two nephrologists that do you guys order anything different here at first, or something you want to add?
No, probably the PTH we may not start when only we have like advanced CKD, we order PTH. Probably all the other investigations we usually definitely we do go ahead with that. Yes.
Okay, you're right. I mean, that's what I was. One of the reasons also I wanted to tell that talk is because I would like to know what you guys are doing differently in India. Yes, and the PTH, the reason we do that as part of the Cadigo Guideline, the first time you see it, and after that depends on the degree of CKD. The main reason I do it as a baseline. Give me one second. So, and then the vitamin D, you'd be amazed that when I was in Texas, which we have more sun, there's more there's more vitamin D deficiency than even in Montana, where there is really cold. Is because the reason I'm thinking is because it's so hot that people try not to get out, you know, and then also the darker the skin, as we know, the longer it takes, right? And then I'm mainly a urine protein creatinine guy, but I think I should also be moving to albumin creatinine. But the main thing I put first is medication review, right? Doctors, because there's so many times I will see someone and then just by review the medications, I will have a good idea why they have acute kidney injury or why they have chronic kidney disease, but why they have increasing creatinine, right? So they have those things that we all know, those NSAID that can do it. Sometimes we're thinking about PPI, pantoprazole, that can cause both acute intestinal nephritis and chronic intestinal nephritis. But they have other things that sometimes that can cause increased serum creatinine, but not really causing much, you know, kidney. I mean, only an increase in creatinine, not really a decrease in kidney function. So one of the things that I try to tell medical students is fenofibrate. We don't use it too much here in the US, but this is known to increase serum creatinine. And then by stopping it, sometimes you can see that decrease. Now, the one thing also I told them is that if you see someone on fenofibrate who used to have proteinuria, and the proteinuria is better, just know fenofibrate also can decrease the proteinuria. So when you stop it, you have to anticipate that the protein might get worse. And then the other thing we're talking about is Bactrim, trimethoprim, that can cause increased serum creatinine and other things sometimes because that's the one thing. And then urine analysis, I spend a lot of time talking, even my patients, they will know. Let's say I don't eat meat, I'm a vegan, right? Since past 2.5 years. So my patient knows that my urine pH will be closer to 8. And then if they're eating a lot of meat, when I see them, I'm like, oh, you've been eating more meat. They're like, oh, do you know? Because your pH is at 5.5. They're like, what? And then I tell them too, you know, because your pH is 5.5, you might have more protein in your urine. It's not showing in the urine, in the micro, analysis, because the lower the pH, the less likely you're gonna see protein there. The higher the pH, the more likely you're gonna see protein. So you can have a false positive and false negative. And so in the UA, also for the medical student, I go with each one, right? So specific gravity, that's very important, because what I tell them is like, is the poor man osmolarity. I usually don't order osmolarity unless someone have hyponatremia in the ICU. I look at the specific gravity. And the good thing about the specific gravity as well is because specific gravity can tell you way years before if that, that's the first thing, if you cannot concentrate your urine, that can be someone who, I don't remember that study, but there was a study which showed that if you cannot concentrate your urine, it could even impair neoplastic syndrome. So let's say that could happen years before you develop the thing. Also in patients like me who are prone to have sickle cell, or the first thing you have is isostenuria, when you cannot concentrate your urine. Now, the renal panel, obviously, will look at sodium, potassium, bicarb, and then the bicarb for me is very important because I try to stay with guideline, and I try to do the same thing all the time, because I don't try to go with my feeling. And one other thing I believe in is, as a Cadigo, for the guideline, it's also anyone who have a bicarb less than 22. I don't put them on sodium bicarbonate at first, because most of my patients, I'm very big in nutrition. I try to have them eating more fruit, more vegetable, but in some the one that won't follow that, I put them on alkaline therapy, either sodium bicarbonate or potassium citrate, depending. And then Cbc and differential. Now, I'm not sure if the guideline asks for differential, but I get a differential, and I get a retic count, and also I get a B12. And then later on, if they have anemia, when I'm gonna do the workup of the anemia, I get iron panel, I get the ferritin, I also get B12 and folate. Now, most of my patients here, I tell them, look, take folate and B12. It doesn't matter what, if your folate is normal, if you can take it, take it. Now, you might say this is overkill. I'm fine with that. I think that's one of the things I do, because there's not much evidence to say that's going to decrease the progressions. But one other thing I do with the vitamin B12 is, just remember, for vitamin B12, if you have AKI or Ckd, you cannot go with the normal vitamin B12, like this, it's 300, it's good. If you have Ckd, we expect it to be a little bit higher, because as we remember, B12 is one of those hydrosoluble vitamin, right? So if your GFR is lower, that B12 is gonna stay longer, just like ACE, just like A1C. That's why we don't use A1C to see if your diabetes is controlled, because as your kidney function get worse, you have less requirement for insulin. So your A1C might be looking better, but that doesn't mean your diabetes is controlled. But again, for the PTH, and I agree with you guys, the one with the PTH, sometimes when I get it at first, and it is high, and then patients say, doc, it's high, you're not gonna do anything. I'm saying, we are doing, it was just a baseline. And then the other thing I try to tell them is, we don't really know what will be a normal or expected PTH depending on your kidney functions or stage in CKD. Now, I think the last recommendation we had in that was the Keto Guideline. That was maybe 2003. Who was trying to say, okay, if you have CKD4, maybe a PTH of 150 is okay. So for me, I use it as a baseline, and then I try to focus on it. I don't try to put medication at first. I try to do the nutrition part. I try to do the whole holistic approach first before. And then if they have low vitamin D, that for sure, I give them some vitamin D while I'm watching the calcium. Next slide. Next slide, please. All right. All right. Oh, okay. So we had all those things here. I was talking about the. Oh, this slide for the medical student on the chart, I get it from webpath, webpath.com.org. But this is really good. Webpath, not only you can learn about nephrology specific things, it's good for basically anything pathology. So that's why we were talking about the pH is important, the protein, the ketone, bilirubin. Now, let me say something about bilirubin. If you're looking at your urine, Doc, you guys looking at your own urine, correct? Hello?
Yeah, yes, we do. Yeah.
Okay. Now, if one of the things that here in the US is in training, we look at urine a lot, but in practice, depending on where your practice. Now, I'm in my practice, in my own practice in Texas, in the process, like barely starting. I'm gonna have a microscope at first, but if you work for a hospital, sometimes they make it very difficult. When I was in Montana, they make it difficult for me just to get the microscope. So this is a skill that I've kind of lost in the last 4 years. But at least one of the things I remember is, don't tell me you see 50 higher line casts. Don't tell me you see 100. Because when you tell me that in someone have liver disease, I'm thinking about bilirubin cast. You know, do you guys like to print anything out about that, about UA?
The sense that the urine analysis, we don't routinely do it for all the patients, only when there is any kind of an acute kidney injury or something. If we want to see what kind of acute kidney injury it is, we go ahead with the urine examination. We don't do it for all the patients who will come to the outpatient department, but we do it selectively, actually.
All right. Next slide, please. So this is a hyaline cast. Next slide. This is all right. This is not a hyaline cast. It look like, but as you can see, there's bile there. So if you see that, that's what a lot of times you will say, okay, it's hyaline cast, but if they have bilirubin, so that could be something that I get confused. One time, sorry, 3 times, and then 2 times I had a resident with me, and then I had to go downstairs and go ahead and review it again, and then it was more like this. Next slide. This is the typical granular cast. Next slide. Renal tubular, that could tell you like tubular injury. Next slide. And again, all those slides, they're on WebPath. Next one, please. So that's the typical one we see in pyelonephritis. That's also in WebPath. Next one. This is the one that we see in someone who have waxy broadcast, someone who have end-stage renal disease. If they're making urine, sometimes you can see that. Next slide. That's someone who have like, nephritic syndrome, and then you're thinking that, okay, that could be a renal injury, red blood cell cast. And then the next one we see maybe gonna be what we call a Mickey Mouse. Let's see, next slide. Hold on, that's a cystine. Next one. All right, do we have a medical student here? Any medical student, what are you seeing? All right, that's the Muddy Brown cast. Next one. And then the one on top is the renal epithelial cast. Next one. Okay, we can go to the next slide. Next one. Next. Okay, now when we look at hematuria, I try to say, hey, I see we are microscopic, or we try to change the term, apparent hematuria. So I try to put them in any of those boxes, right? If someone have, let's say, malignant hypertension, I'm thinking about vascular, renal vein thrombosis, if they have, like, let's say, membranous nephropathy, very low protein in the urine. And I try to rule out the big things, right? And if they're, I'm thinking about if they have polycystic kidney disease, I'm thinking about interstitial, and then and then I'm thinking about malignancy, and then I go with metabolic, let's say if they have a kidney stone or not. And then if they were exposed with toxin, that's also something that can cause hematuria. Now, if they don't have any of that and they don't have a urinary tract infection, that's when, again, we think about glomerular, right? Because usually when they are referred to source is because everybody thinking they're gonna have a glomerular disease. Now, the main things we even here in the US is IgA nephropathy. That's one thing we'll always keep in mind. And also, I've seen a patient who had thin basement membrane, and then if they have hearing loss, we want to think about Alports. But those things really, you make to make the diagnosis. I know in other countries you make you don't do biopsy for IgA, but here in the US we still get, even though we think it's IgA. After we put you, I probably would put you on treatment empirically for a month or 2 or 3. But if they have a second episode of hematuria, things like that, we get a biopsy, even though we think it's IgA. But we like making the diagnosis with a biopsy. Next slide. So basically the same thing we said. Think about UTI, kidney stone, and we go. Next. Now, the reason I put that slide, that's from up to date, the main reason I put this is to stress the importance of albuminuria. Well, that's also knowing that importance. That's why here the FDA now will not approve any diabetic medication if they don't decrease, diabetic medications for kidney purposes if they don't, that medication will not decrease albuminuria. As you can see, albuminuria have good correlations with CKD progressions and as good as CVD and mortality in general. So every medications that now we're talking about SG, sodium glucose transporters, right, which is the big kid on the block, they decrease mortality, but we also have some good evidence that decrease proteinuria. So I'm not saying the only way to decrease mortality is decrease proteinuria, but all the medications that decrease mortality, ACE, ARB, they decrease proteinuria. So, and as you can see, proteinuria have very good correlations with CVD mortality, right? And then it has even less progression of kidney failure. And then guess what? We try to focus a lot on proteinuria, but there's not really evidence that controlling the proteinuria will control the CKD progression. Just like in ACE and ARB, they're good with proteinuria, but we think they're paramount. There's this first step in patients who have CKD, especially if they have diabetes, but there's not overwhelming evidence that they decrease kidney failure the way that we think they would. Next slide. Next slide, please. All right, this is the statement I was saying about the change in albuminuria and GFR as endpoint for clinical stage. So the FDA is looking into that. So basically, if you don't, for you to try to get away new medications, if your new medications are gonna decrease eGFR or albuminuria, you're probably not gonna get FDA approval. Next slide. Same, next. Next, please. So now one thing is missing in that proteinuria workup will be the sodium glucose transporter. But even here, nephrologists, endocrinologists, cardiologists, we're really excited about those drugs. But the primary care doctors, the one that seem, we see really the patient, they're not really on board yet for, as you know, because the UTI, the concern for DKA, the concern that's not validated in the other trial for the amputation and stuff like that. But the one thing we'll do, every patient will get a urine protein creatinine ratio. We make sure we put you on ACE inhibitor, right? Or ARB. I mean, my drug I go to is losartan. But there was some issue with losartan, probably linked to, there was one, was it one losartan salt, I think was from India, is that correct? There was some issue with increased risk for cancer, something like that. But that's the one I still use. Calcium channel blocker. One of the things I try to tell, yeah, the glofazine, I'm seeing someone saying about the glofazine. Yes, that should be there. The glofazine should be there. It should be.
Okay.
Sorry for that, Dr. Paul. Sorry for that interruption. Please go ahead. Please go ahead.
Oh, okay.
Sorry for the interruption.
I was trying to read. Someone asked something about clinodipine also. I don't think we have that in the US. Here we have amlodipine, but they also calcium channel blockers, the hydropyridine. And just so you know, diltiazem we don't use much in the US, but diltiazem have shown to decrease proteinuria, but we don't use it. We use amlodipine, which can sometimes increase proteinuria. But the reason we do that is because we are more comfortable using amlodipine than diltiazem, especially because we don't have to worry about effect on heart rate and things like that. But you can use either one of them. Now, a lot of nephrologists don't really want to go with spironolactone. I'm a big believer of that. I use it a lot, and I use eplerenone in someone who, younger, patients who doesn't have, because remember, spironolactone can cause that gynecomastia, it can cause that decrease in libido. But if someone, all they can afford is spironolactone, so that's what I will use. Also, just so you know, there's a new drug that FDA approved in the US called finerenone, which is different. It's a non-steroidal, just like mineral corticoid. It is as strong as spironolactone, but more specific. So it's FDA approved for that. It's finerenone. And then blood pressure control. At the end of the day, we think if your blood pressure is controlled, you have a good chance for decreased progression of CKD, decreased proteinuria. Now, nephrotic and nephrotic range proteinuria, I think the main things we want to know, if you have nephrotic range, we want to make sure, every patient I've seen, I'm going to check their, if they haven't have any, I don't check lipid panel on every patient, but this is one of the patients I will check. Some of my patients I basically would start them on statin if they meet criteria, independently of their lipid panel as per Cadigo Guideline. But the nephrotic range, that's when it makes a difference for us to see, okay, if I see someone with diabetic, right, and then come with a 3.5 gram, and then diabetes is uncontrolled, he's not on ACE, he's not on ARB, he's not on glofliflozin, as you guys call it. I might walk up that patient for another 3 months. But if the creatinine was like 1 and then it's 3, the progression is really fast, I'll be like, okay, let me biopsy that patient. I try to biopsy at least 30% of my patient with diabetes, because if you're not getting biopsy on your patient with diabetes, you're missing other things, because not because someone has diabetes, that doesn't mean they cannot have glomerulonephritis. Next slide. Anyway, this is again to exemplify the correlations with proteinuria and CVD mortalities. Next slide. So again, I have a whole lecture on nutrition in CKD. As a matter of fact, I came here last week as a consultant here for Jacobi Hospital, which is in the Bronx, part of the New York health system, New York City. And then and I said, hey, I have a lecture that I would like to give. I said, which one? I said, nutrition in CKD, because this is something I really like to talk about. And then main reason is because as nephrologists, I think we are focused on a lot of things. We don't really spend much time talking about patients with nutrition. But as you can see, nutrition, metabolic acidosis, we all know that. And what is Cloto? Cloto, Cloto FGF23 / Cloto, those things they are a marker that is not really for prime time, but we know we want your Cloto to be in check. If your Cloto there's a relation between, just like there's a relation between potassium and calcium, and there's that same relation. No, sorry, not for, I mean, phosphate, your phosphate and calcium. As you become in CKD, your phosphorus go high, your potassium start going low. Same thing with Cloto. As your Cloto decline, your FGF23 goes up. Now, when they look at FGF23 and Cloto to see if getting those things in check early, if that could decrease the progression of CKD or cardiovascular disease, we haven't been able to see that. All right. So low protein diet for some nephrology, this is controversial. They don't think the low protein diet will basically change anything for the patient. That he does it because less BUN. But in some patients, if you do low protein diet with supplemental amino acid, you might delay the progression of CKD. Now, one thing that should be no controversy is vegetarian diet, right? So if you follow a vegetarian diet, and then as I think you were mentioned earlier that about the India becoming a lot of diabetes, but you have to see also in the past 20 years, 30 years, what is the amount of meat or animal product that people are eating in India compared to previously. Is that correct?
Definitely. The food habits have definitely changed. The lifestyle has definitely changed. Definitely that's contributing to the diabetes here as well.
Yeah, westernizing the diet is never a good thing. All right. So next slide.
Steaks and burgers are picking up here, Dr. Paul.
I'm sorry?
Steaks and burgers are peaking here in India these days.
That's right. Yeah, those things are not good. Yeah, those are, I mean, I don't eat them anymore.
That's
that was it.
Good for you.
Yeah, I put that thing in there. So even after an MI, the more protein you eat, the higher your risk. Oh, next slide. Oh, all right. So I think we're gonna do that one, and then we're gonna take some questions because I'm seeing a lot of questions coming. This is one of my favorite slides. So when I talk to medical students, as you can see, do you see that thing that is blunted there? I told them, what about if I can come up with a medication that will decrease the fat, decrease the carbohydrate, increase the fiber, decrease the protein, more important, I'm sorry, very important. Decreased protein is important, not just for uremia. Look at what decreased protein does. Decreased protein will decrease age in the galactose end product, decrease uremia in toxin, decrease LPS, but way more than that. When you do that, what happens? Your symbiome, which is the good microbiome, they go up, all right? And the pathobiome in your body go back. So there's evidence in end-stage renal disease patients that depends on the quality of protein that you eat that can feed the pathobiome, the bad microbiome, or feed the good one. So this is important. Now, what happens when your phosphorus is low? Decrease phosphorus, decrease FGF23, which is a marker for inflammation, and increase Cloto. All right. So these, and that's proven, if that happens, that can decrease the GFR degradation, right? If you decrease your acid load, obviously you have less acidosis. That also slow down GFR, degradations, or slow down progression of CKD. Same thing with salt. So what about if I could come up with a medication that will do at least half of that? Will you prescribe it? Right? That's what I tell any medical student. They say, yeah, I'll prescribe it. Next slide. So more about vegetarian diet. That came out in 2019. Kalam Akhtar, I think he's from West Coast, between San Francisco, I think it's San Diego. He does a lot of research in CKD. So this is recommendations. This is not controversial. anyone that have CKD, any stage, you should get 50% of your protein from plant. Next slide. Next slide, please. Again, you can go over that. You guys are gonna have access to all the slides. I think we're gonna put them on SlideShare. Now, here's the most important thing for me. I see something about the SGLT2s. The main reason they're so important is because they decrease they decrease intraglomerular pressure. That's why when you put someone on any of fliflozin, sotofliflozin, by the way, there's one right now we call sotofliflozin, which is both SGLT2's inhibitor in the kidney and SGL1 in the gut. All right. I don't know which is that going to be any better, but the main reason when you see that anything that decreases intraglomerular pressure will decrease glomerular filtration rate at first, just like ACE, just like ARB, just like low protein diet, just like SGLT2s. Anything that do not decrease intraglomerular pressure, like high protein diet. What is that diet that everybody's going crazy about? That diet high in meat and keto diet. Keto diet, yes. Keto diet won't do the decrease in intraglomerular pressure because it doesn't do that. What happened at first, you have a bump in your GFR. So if your GFR was 60, you start keto diet, it goes to 65, maybe 70. But guess what? You know one thing that also will increase GFR at first? Diabetes, right? When you first have diabetes, what you have? You have hyperfiltration. So that's one way I try to explain that to my patients. Some of them will get it, but some of them will like, I lose weight. So what I tell them is, if you're gonna do keto, do it for 3 months, but don't stay on it. Next slide. Next slide, please. So again, here's the slide showing like, that's why I don't start my patients on medications when the bicarb is less than 22. I start them on fruit and vegetable because that study have shown not only it will decrease, it will improve GFR, but it also decrease blood pressure when you eat more fruit and vegetable. And then there's no doubt about it. Next slide, please. So role of phosphate binders. In the US, any nephrologist see a patient at any time, any bump in the phosphate, boom, they put that patient in a phosphate binder. Me, I try to talk to them about diet and nutrition because when you put someone on phosphate binder, you basically have to keep them on that. All right. Same thing about Cloto and GF23. If you focus on control of phosphorus, your Cloto will stay high and your LGF23 will stay low, which is the way you want it. Next slide. Oh, here's one thing when I talk to people about phosphorus. They're like, oh yeah, but these have a lot of phosphorus in it. Yeah, but you only absorb 50% from the animal product. I'm sorry, from plant-based, and from animal you can is between 40 and 60. But if it's inorganic phosphate, just like in McDonald's, you get 90% of it. So it's not much phosphorus there's in some things. Is how much of it where it comes from, right? If it's plant-based, it doesn't 50. If it's animal product, it could be 50 to 60. And then if it's inorganic phosphate, it's much higher. And then one more thing also, look in medications. Sometimes medications have phosphorus in them. And then especially in the ESRD, patient with dialysis, that could make a big difference. Next slide, please. CKD, MBD, we kind of mentioned that a little bit. So that's the definition. It's just not like your regular osteoporosis. Here we focus on a lot in secondary hyperthyroidism because this is what CMS, which is the rule, want us to do. But one thing we don't talk much about is adynamic bone disease, which is the bottom one, which is also as bad as secondary hyperthyroidism. Next slide. So I kind of put that also for the medical student because I get those things all the time, and they say, "Doc, I have someone with osteoporosis. Which medication should I use?" So I show them that slide, and I tell them which one you will use. Right? Any GFR. Which one can you use at any GFR? And they say denosumab. I say, okay, good, but remember, denosumab can cause a lot of hypocalcemia. So you have, this is one of the few times that I'm okay with someone putting my patient with end-stage renal disease or CKD4 on calcium, because I've seen denosumab bottom down calcium to like 5. I mean, corrected for albumin, yeah. So it can happen. Next slide. All right, this is the workup. Now, one of the reasons I put that in the slide, I was talking to medical students because sometimes they were like, hey, should we get a bone biopsy to know? I'm like, yeah, unless you're gonna go and do it in a tertiary center where they really know, but I don't want anyone to do biopsy on my patients to see if they have CKD MBD, and the next thing you know, they end up with an amputation, or that the wound never. Okay, so next slide. Diabetes, that's what it look like. Now, since we're talking about that, I've seen a lot of I've seen 5 idiopathic nodular sclerosis in patients who don't have diabetes, and all they had is smoker. Have you guys seen similar, doc, in India?
Sorry, I didn't get the last part of the question.
I've seen a couple of patients with idiopathic, I get biopsy and it looked just like that. Okay, someone said yes. And then there were no diabetes, no history of diabetes, no more A1C, and then all they had was a smoker,
Yeah.
But
once in a while we do see patients, yeah.
And then, but guess what? All of them went from diagnosis to dialysis in like 3 months. Very aggressive. Yeah. Next slide, please. So my goal, as I said, right here, I should put SG, sodium glucose transporters. That should be mainstream. Actually, after ACE, this is exactly the same thing I will put there. I try to get all my patients to hemoglobin A17, depending on the age. Older folks, like 70, 65, I'll be okay with closer to 8. But younger kids, I would say really less than 6.5. But around 7, I feel comfortable. Next slide. Oh, man. I wish I had more time to talk about all this. But anyway, this is, if you look at this slide, now you're going to understand why those SGLT2s are game changers. Because so far, we don't have any medication that do anything for kidney fibrosis, for tubular institution, or mesangial, right? So those medications, it seems like there's data, those SGLTs can help reducing the feedback, right? The TGF, tubular glomerular feedback, right? So in diabetes, it is up. You want it to be lower, neutral. So it seems like that could understand why. And then also, one of the reasons I put that slide, I was way before I started looking at that, is also why nutrition is important, right? Because if you eat the way you continue eating and you have the best medications, nothing's gonna change, right? So I think that could explain why SGLT2s they're gonna be a game changers. They're gonna be the next statin. They're gonna be something that's really revolutionized the way we treat patients with diabetes and CKD. Next slide. Go ahead. Next slide, please. All right. That's another way to exemplify what happened in diabetes. As I was mentioning, the first thing was hyperglycemia. And another thing that happened at the same time with hyperglycemia is hyperfiltration, GFR high. So when someone tells you they're taking keto and the GFR is high, say, okay, just like diabetes, huh? Really? Right? And then the kidney complications, as you can see, depending on in which, if you control or not, those things really can happen like 20 years after. But before that, you have all those things we talk about, right? So that's why SGLT2 inhibitors are game changers if you start early, because they're gonna be helping with at least with the cellular injuries and then the tubular tissue feedbacks. All those things happen way before we start seeing microalbumin. Think about it, right? I think right now the recommendations are, because the trial is you start someone diabetes, boom, you start them on ACE and ARB, then you add those SGLT2. That's what we're gonna be doing. But I think maybe in 10 or 15 years, we're gonna change. We're gonna start those fliflozin before we even start ACE or ARB, you know. And also the cardiovascular death. That's what most patients with diabetes and CKD that end up dying, all right? Next slide. Okay, this is the contemporary management of kidney failure, all right? Blood pressure control, RAS blockade, glycemic control, SGLT2 inhibitions, and weight loss. Next slide. Next. Now that answer, we all have it. Are SGLT2 inhibitor ready for prime time? Yes. Move on. The DAPA CKD show that, right? DAPA CKD, as you know, there were diabetic patients and non-diabetic patients. I think about 68 have diabetes, or 60%. 2/3 have diabetes and 1/3 have diabetes. And then there was there were like 50% CKD3, GFR less than 25. There was about 15%, and then the vast majority was between 30 and 60. So yes, they are ready for prime time. And then in the study, they show benefits even in patients who don't have diabetes. So when are we nephrologists going to start using those medications in patients who don't have diabetes? I don't know, but one thing I know, I'm going to be one of the first ones. Next slide. Okay, this is up to the DAPA CKDs that are there, but I think we can add it. This is all this trial on the SGLT2s and a different kidney endpoint. Again, it's there for you. Anyone can review it, but I will, as a nephrologist right now, we have our own trial, which is DAPA CKD, and then that's the one I will be talking to my patient about. Next one. I just put that there because there was some issue with the first trial, the canvas. There was some of the risks, but in the repeat one, it didn't really show much of the imputation that we showed in the previous one. So that was that trial came before the DAPA CKD. So as you can see, there's a decrease in 1.5 compared to the placebo. Also, even renal adverse effect, that we will be thinking that there was less in the canagliflozin arm. New onset albuminuria was lower. GFR decline was much lower. That's significant when you think about it. End-stage disease will not cause mortality. That's great news when you think about it, right? And then I have to update my slide to put the newest trial on that, but that's one of the reasons we want to use that. Next slide. Okay, we can go. That was the one I talked about the amputation, but it didn't show in the other trial. Next slide. I think I put that just for the medical student, to see which way, so why they might end up causing that euglycemic ketoacidosis is because beta oxidations cause that ketone. The ketone synthesis, that's why I might end up having the DKA. But the way I kind of see that is, we know ACE inhibitors can cause angioedema, right? But we still prescribe it. So why should I hold a medication that can decrease progression of CKD because they can cause euglycemic? I just have to monitor for it. Next slide. Anemia. One thing I would say for the medical student, just know the role of hepcidin, and in the world of HIF-PIF, which is the one that's gonna be, which is gonna stimulate erythropoietin release. And instead of giving ESA erythropoietin to those patients with CKD or advanced CKD or ESRD, we're gonna try to come up with this HIF. And then there's this trial. So far, when I put someone, my patient right now, I put them every other day. I don't give them iron daily because there was a trial that showed not only is as good as daily, it causes less GI symptoms, and if done correctly, you can escape the hepcidin effect, which is hepcidin is a molecule that's high in inflammation. So when hepcidin is high, even though if you have iron, you won't be able to use it, you know. So it's kind of cause some kind of relative iron deficiency anemia. And then we see that. That's why we used to call anemia of CKD or anemia of chronic kidney disease, but really know is that it's hepcidin. The spelling there is not good, it's hepcidin. Next slide, please. I mean, here in the US, we have that Orexia, which is FDA approved. It's good, not only bind to the phosphorus, it's also can help with patients who have anemia. Funny enough, if you see the previous slide, can we go back to the previous slide, please? All right, you see that one here is ferric citrate. Before the Orexia was FDA approved, we could go and buy that over the counter. Patients could go and buy ferric citrate in the Chinese store, right? But guess what? You cannot find it anymore. These used to be like what? I don't know, $10, $20 for a month. Then now you have the Orexia that costs like what? $300 for a month. But no wonder things are different here in the US. Next slide, please. Next one. Oh, this is a slide from Nature Review that's kind of exemplify what the world of hepcidin, as I was talking about. Hepcidin goes up, ferroportin goes down, and then iron absorption is decreased, iron availability is decreased, and then you can end up having functional iron deficiency. Another thing I would like to print in that slide too, just know ACE and ARB can cause some kind of anemia. Lipid management, statin. Next slide, we're gonna see the Cadigo Guideline. So basically, if a patient has CKD and diabetes and age more than 18 years old, they should be on statin. If a patient has CKD, they don't have diabetes, but they're over 50, they should be on statin. If a patient has CKD, no diabetes, that's when you get a lipid panel to calculate the Firmin-Gamma score. And if it's more than 10%, they're on statin. So basically, this is the only time I will get a lipid panel. If they have CKD, no diabetes, and they're not over 50, they're between the ages of 18 and 49. They don't have coronary disease, they don't have history of stroke, then I'll get lipid panel to calculate Firmin-Gamma score. But usually, as you can see, the vast majority of patients who are CKD should be on statin. And those are not my guidelines, they're the Cadigo Guideline. But as you get here in the US, we are not really doing a good job on that. Starting patient on statin that needs to be on if they have CKD. Next slide. Next. I guess this slide was mainly to see, hey, if someone have dyslipidemia, try to see what the reason they're taking it. Sometimes it could be medication, sometimes it could be something else. So rule out secondary cause of dyslipidemia, and then go yes or no. And then once you put it, it's fire and forget. That's it. Do not measure LDL cholesterol unless that will alter the management. Next slide. Those are the possible secondary cause of dyslipidemia: medications, nephrotic conditions, hypothyroidism, diabetes, hypothyroidism, diabetes, beta blocker, diuretic, cyclosporine, those things can do that. Next slide. Next. All right, this is, again, is a yes or no, the same thing based. 18 years old, diabetes, CKD stage 3. By the way, CKD stage 2 and above. CKD stage 3 is starting. Next slide. Next. Yeah, I put that also for the medical student, just so as you can see, right, and the fenofibrate, if you have CKD 1, 2, or CKD 3, the dose different. By the time you CKD 4 and 5, you should not be on fenofibrate, right? If you're on transplant, you should not be on fenofibrate. Nicotinic acid, we don't use that anymore, but atorvastatin, if you transplant, the maximum dose is 10 to 20. Don't put someone who's on transplant with a high, and it's sometimes it's because of the tacrolimus of the cyclosporine they're taking. But the recommendation, that's what it is. Rosuvastatin, maximum in transplanted 5. Simvastatin, maximum is 5 to 20. So those are guidelines. If I try to stick with those things because if I do something I didn't know, okay, but if it's in the guideline, it's best to follow it. Next slide. All right, hypertension is complicated, right? So many trials, but one thing I'll tell you is the same thing as nephrologists, right? We want our patients to have controlled blood pressure, but for them to get there is a step by step. If someone comes to me and the blood pressure is like 160 over 90 over 100, my goal is to get them to 140. And then when I get to the 40, my goal is to get to 130. So, and we know, yes, if your blood pressure is 120 over 80 or 115, as a matter of fact, over 75, you have less risk. But it's how you get there. If you get there with hypertension, if you get there on 5 medications, it's different. But if you get there with exercise, with nutrition, with 1 or 2 medications, that's the way to go. Next slide. Next one, please. Yeah, so this is the group of medications, the centrally acting alpha agonists. I try to stay away from them. Beta adrenergic blocker, they're not first line. The first line really are the angiotensin converting enzyme, the dihydropyridine, and the thiazide. Direct vasodilator, I try to stay away from them too, right? And the mineral corticoid, which if you're gonna be using, I'll use a lot, but you have to really watch their potassium. Next slide. So again, that's a question I put there for the medical student, but as we know, the answer is reduction in intraglomerular pressure. That's why the ACE and ARB, that's what they do. That days to weeks. But one thing we should know also, months to year, they also reduce glomerular permeability to protein. That's one of the reasons I don't stop lisinopril. I don't stop ACE or ARB. Even I'll probably decrease the dose to, very, very tiny one. But whenever possible, even though the blood pressure is controlled, even the protein is controlled, I try to keep them on some amount of RAS blockade because they reduce glomerular permeability to the protein months to year. I don't know if I remove it, if it will stay. Next slide. So kind of the side effect that we all know. We can move on. Next slide, please. And then that's why it's so complicated, the guideline, as I say, for hypertension, it looked like a yo-yo. First, it was like, Gen C, and then blood pressure more than 105, diastolic, wow, that was really, anyway, don't do anything for blood pressure. Then 160, and then 140, and then lately it's now 130, which is the last one, 130 systolic to 80. Next slide. So this is what I follow. I mean, depends on the stage 3 to 5, 130 to 180. And in stage 1 to 5, I try also to get to that, but that's the Cadigo. I will go with the 2017 ACC AHA 2017 guideline. Next slide. Next one. At the sprint trial, we can go next slide so we can try to wrap up again. All right, now this is it, right? You remember that drug I told you? It's vegetarian diet. This is the drug that do all that, right? Decrease protein, increase fiber, decrease phosphorus. We should talk to our patients about vegetarian diet, especially in India, right? But here's one thing I find out though. Some of my Indian friends, even with vegetarian diet, they have increased risk for diabetes. I mean, my brother-in-law he's from India. The guy is really clean, but he still have a lot of diabetes and hypertension, even with all that. Next slide. There's any marker for CKD progressions? We'll look into some of those. Next slide. One of them was fibrinogen, but really, fibrinogen to see if there's fibrosis, but that's mainly clinical trial. Next slide. And again, wrap up here when to refer to specialists if they have hematuria, nephrotic range proteinuria, diabetic with multiple comorbid, uncontrolled refractory hypertension. One thing I would like to say about refractory hypertension, before you call someone refractory hypertension, make sure they are on the diuretic. If they're on 3 medications, one of them should be a diuretic. If they're not on a diuretic, you should have a good reason why. And also anemia, you probably have to send it for the nephrologist because we can manage that one too. Next slide. Same thing, or everything in red and maybe in yellow if they have really a bunch of protein in their urine. Next slide. I'm not going to talk much about that indication for kidney biopsy, proteinuria. This is also for the medical student. I mean, how to read about when you do a biopsy, what to follow. Next slide. Keep going, please. Next slide. Next one. Next, please. Next one. All right, that I kind of put there because now with the SGLT2s, we need to look into those things as well. When someone come with AKI, when you ask for sulfonylurea, ACE inhibitor, diuretic, metformin, ARB, NSAID also add for sodium glucose co-transporters. Next one. This is where I get most of my slide and stuff. Now let's see. Where are some of those questions? Okay. What about SGLT2, glofosine? Then the clinidipine, I kind of mentioned that. What about canagliflozin over ARB? Yes, I agree with that. I think if it was up to me, I probably would start with canagliflozin before I even start with ARB and ACE inhibitors. I agree. Indian diet is mostly vegetarian. And then one other thing I do myself, I eat a lot of turmeric, and I believe in that. I believe the effect to decrease inflammation of the turmeric. B12 deficiency, definitely. Anyone that's on metformin will become B12 deficient because metformin competes with absorption of B12. No. So anyone that's on metformin should be on B12. Gloflozin underwent trial. I don't know if all of them, but they keep coming with them all the time. And then, as I said yesterday, there was that trial about the sotagliflozin, which is both SGLT2, SGLT2s, and 1. So sodium glucose transporter 1 and 2. So that's probably gonna. Now the finerenone is by Bayer, right? Bayer. Good thing about it, yes, it's another thing for us nephrologists, but I don't know. I probably will use it, but I'll use it after I use SG, sodium glucose transporters. So because the data are stronger for the sodium glucose transporters. Now, I probably will use it in someone who have diabetes and control hypertension if they can get it in case instead of spironolactone. So I think that was the only question I have there.
Thank you very much. You have covered almost all the key areas that is very relevant for the clinical practice of nephrology. And once again, thank you very much. And I wish to ask or discuss a few areas which you have discussed in your presentation. Shall I?
Go ahead.
Okay. First is regarding the prevalence of CKD. And one issue we are facing now is most of the laboratory in India is now also reporting estimated GFR along with the creatinine. So for example, an female aged more than 70 years, even if the creatinine is 1, GFR will be less than 60. For a male 70 years, the GFR will be less than 60, even if creatinine is 1.2. So these all groups will be automatically labeled as CKD if you strictly go by the GFR criteria. And we get a lot of referrals from general practitioners, and also patients come to nephrology OPD directly without any reference, seeing this low GFR reported from the laboratory. So how do you take this concern?
No, you're right. Look, there was, I think about 2 years ago, there were nephrologists wanted to change the criteria so that way, if you're over 60, you don't categorize as CKD. But here's the thing, though. The reason that thing would push forward is because, remember, it's a screening. So when I see my patient, they say, hey, you come to me at GFR of 59. I'm like, look, and I tell them, look, now, I just send the calculator. I use the same thing as you. I'm like, okay, let's say right now, you're 60. I'm going to make you 40, all right? You see what happened? So now, can you really change your age? No, but why we're not changing that? We're not changing that because it's a screening test. We want to get more people in, right? Now, there's going to be a time that we're probably going to say, hey, remove the age. Now, by the way, as you know, in the US right now, we are not using the GFR for African American anymore. We're getting away from with that. So GFR with African American, as you know, if you're African American, or what we call it, Black, right, your GFR will be higher for non-Black, but we don't use it anymore. We try not to use it. You know why? It's because Black was getting referred to kidney transplant later. Right? So that's a disadvantage, right? So, and again, when they measure, remember, we estimate creatinine. Well, when we measure creatinine, like statin and stuff like that, or other nuclear things, there's no difference in race, right? So if I see someone that really want to know, I tell them, look, this is what it is, but if you want, there's a way I can measure it, but I don't recommend it. Let's say if you go to Mayo Clinic, everybody get a cystatin. Everybody get it. Yeah.
Okay.
Next one.
Yeah. Next is regarding vitamin D in the initial assessment of CKD patients. Most of the studies from India, population-based studies, has shown that the prevalence of vitamin D for normal population is 80 to 90%. 80 to 90% of Indians are vitamin D deficient or insufficient. So there are a lot of postulations for this high prevalence of vitamin D deficiency. One is we all are black, dark skinned, so a lot of melanin which prevent the ultraviolet rays getting inside. Next, longer. We don't eat that much cheese, yogurt, fish liver and all, which are vitamin D rich foods. We don't use that much common. And third is vitamin D binding protein levels for Indians are less. So as the vitamin D binding protein levels are less, automatically the total vitamin D levels will be less, but free vitamin D will be normal. So the usual cutoff for deficiency, that is 30 nanogram per ml, and insufficient deficiency of 20 cannot be considered. So what we usually do, we don't check vitamin D that often for all CKD patients at the first visit and follow, but we just supplement with vitamin D. Because we already know they are all deficient.
That's what I do in Texas. I put everybody on vitamin D, and I check in 30 about 3 months later, because I'm already assuming they're low. In Montana, most of my patients are already on vitamin D. So that's why I check it, because most of them, they're already taking it because they know they have to take it. And you're right. One of the studies also showed that the way for vitamin D, for us to get it, yes, it's important. The darker the skin, the longer it takes. Like say for someone which is like we call lighter skin, they probably need 15 minutes. But important, you have to be chic exposure. What happened in India? What happened in Texas? People, you make sure they cover the face, right? So you're not gonna see someone saying like, oh, let me get some vitamin D, because they think they're gonna have it, right? They're gonna be exposed to it. But if you don't expose your chick to it, your vitamin D will be. My vitamin D when I was living in Texas was 9. 9. All right. Why? Because it was so hot. I never would try to go to the sun, And then the only time I would expose the sun is Sunday for like 2 hours. Right. And the best time also is around 10 in the morning. So yes, you're right. But here's the thing though. One thing you say, I have to say something. When it comes to milk, they have vitamin D in milk is because we put it in milk. Right?
Fortified.
That's right. But now here in the US, they push a lot of milk. But here's one thing I tell the people about vitamin D. Yeah. Okay, you might get some milk in there, of vitamin D, but when it comes to your calcium and bone, milk not gonna help you, because all the countries that drink a lot of milk, they have more osteoporosis. That's something important.
So it is in 2019, Government of India introduced fortification of all packed milks.
Okay.
Till then, we don't have fortified milks with vitamin
So
D.
that's what's your next one?
Okay. Next question is regarding the nutrition in the CKD. So this protein restriction, the issue here is most of the population, our population is already taking less protein. So protein intake may be 0.8 or 0.9 grams per kg. So they don't eat heavy protein like Western diet. So, but most of the patients do read from a lot of social media that they need protein restriction, and most of our CKD patients go into extreme protein restriction, seeing all these advices. So in fact, we have to push them to eat more protein.
Now, yeah, that's also bad, because this is what I did, why I said, yes, protein restriction is good, but the most important thing is not really protein restrictions, is what type of protein. So what I'm gonna tell you, if you're gonna go and say, okay, 50% for CKD 1, 2, and 3, when you go to CKD 4, we say 70% from plant-based. I use a lot of garbanzo, garbanzo, I don't know what you guys call that, chickpeas.
Yep.
You can go. So I eat a lot of nuts and seeds. Right. Now there's one thing I never heard of it until a year ago. We call lupini beans. It's really good because you have net carbohydrate is 0. So I try to go to eat a lot of that. Now, low protein diet, this is something that should be done with a doctor following it, because if you're going to low protein diet, you need to have supplemental amino acid, right? And so that's why I don't tell people to go on a low protein diet. Now, here's the other thing. In general, we don't need that much protein. Right?
Do you use keto analogs of essential amino acid?
That's right. Yes, I have them buy. Yeah, I have them buy. So that way they take it. So that way they don't get deficient. But that's only for people that I have a guy with FSGS. His BUN was like 100 when I saw him 3 years ago. He's still not on dialysis. At the time I was about to start on dialysis, so I have him on the low protein diet, mainly plant-based and supplemental amino acid. His creatinine has been stabilized around 4, and his B1 was as low as 45 at some point. So there's some patients that, and then the main reason I also do it is I think he's 65. He tried to get a kidney transplant, so that way we can get preemptive, kidney transplant. But someone who is not gonna get a kidney transplant, who doesn't have one looking into that, put them on low protein diet just to delay progression of CKD. I mean, as what I said, you have to basically individualize it,
So you said that 20% of your diabetic patients, you might end up doing a renal biopsy.
About 30%,
Yeah.
But again, I look into, I don't know, I think it's on the slide. So if you have diabetes, and then when do I do it, when do I don't? Let's say if you have diabetes and your creatinine, by the way, number one, people say, if you don't have protein in your urine, it's not diabetic nephropathy. That's not true. I've seen patients with normal protein, and then you do biopsy, massive nodular now, what I look though, if the creatinine was like 1, 1.1, 1.2, 1.3, 1.4, 1.5, 2, 2.1, these patients are less likely to get a biopsy. But someone who have acute kidney injury, or scratch 1, and the next thing you know, you go to 3. You know, I probably now, and also I look at the urine, right? If they have blend urine, that's what I expect in diabetic, right? But if they have protein in there, not just protein, they have a lot of like, you know, hematuria, they have like, you know, other I try to get. And usually before I get a biopsy, obviously I will go and then get some immunological panel, say if the ANA, sometimes I will say for Stienka. I look at other things before I stick a needle in their back. But where I guess what I meant is some nephrologists will absolutely not do biopsy in the diabetic patients. And I think this, from one of the study I read, he said, if you're not getting biopsy at least 30% of your patients, you're missing things, you know, because if not because someone has diabetes, that doesn't mean they cannot have membranous, right?
Okay, Dr. Bozos. So we had a very informative talk and a good discussion as well. So we thank Dr. Bozu for sparing his valuable time from his busy schedule. So I'll hand over the session to Dr. Jacob Jesuran for the closing remarks.
Thank you, Dr. Gio and Dr. Arun, for that admirable moderation. Dr. Paul Morio Bozo, thank you so much. We take a bow. That was indeed an amazing session. And I think each one of our students and doctors who attended this session, and also a lot of students who will see this session later on, will really benefit from this session. And from the looks on our nephrologist's face, I can quite evidently understand that a very fruitful discussion just now culminated. So that is very, very, very heartening to say the least. Dr. Bozu, thank you so much. Thank you for coming over. We look forward to another talk on nutrition and CKD from you later on, probably in the next month or in the months to come. I've noted that down very carefully and boxed it. So thank you so much again. Would you like to say any closing remarks before we close this session?
No, just thank you. Thank you for having me. Thank you for the 2 nephrologists.
Thank you.
And thank you for inviting me. Thank you for the medical student that sent all those things in the chat. And then give them my email address, have them connect with me in Lincoln, and then share the slide. And one thing I would like to know, I like to let you guys know, and then I know some internal medicine doctors from India who probably would like to come here and just do nephrology, or some nephrologists who would like to come here and do nephrology. If that's possible, if that's what you're looking for, you want to come here and go back. If you know someone that can do that, all they have to do is pass the USMLE and let me know. I know a program that will accept people with residency in their home country. All right. So I think I just want to say that there too, you know, because I know some people want to live in their country. They want to come and say, hey, I want to come and do the 2 years nephrology, just learn something different, you know, or as a refresher and then come back. Or I do internal medicine. I want to do nephrology. I don't want to do it. I would like to do it outside of India and come back. Yeah, I know a place that can do that. Let me know. All right, let's keep in contact. You take care now. Thank you very much.
Absolutely, Dr. Bozo. That's very kind of you. Thanks for the invitation. We noted that, and definitely we pass it on to our friends and students. And thank you so much, Dr. Gio and Dr. Arun. Amidst your busy schedule, you've paired together and come here and really done this moderation quite well. And thank you so much.
All right.
To our participants, so thank you guys for tuning in. Please do share with other. Hello.
Oh.
Yes. Sorry for that. I'm audible.
broken.
So thank you. Thank you for tuning in. Please do share with other friends also about our webinars. We really put a lot of effort to conduct these sessions for medical students, not only for our institution, but also for all the students across the country, and also for doctors who would love to hear such sessions. We are working hard on all fronts. So thanks for tuning in. And on the 19th, we have a very interesting session on pediatric pulmonology manifestations in children. One Dr. Grace Paul from the United States of America has agreed to talk to us on this very important topic. And we have luminaries from across the nation who are going to be panelists. And we have Dr. Jijo, our own pediatric pulmonologist, who is going to moderate the session. So it's going to be very interesting. Looking forward to your participation and active deliberations. So see you on the 19th. Until then, have a very, very, very safe and blessed weekend, and happy Makar Sankranti and Pongal for celebrating these two festivals across the nation. And signing off from Believers Church Medical College and Hospital and bye-bye.